Hi, folks. I'm Tony Leys from KFF Health News. Welcome to session number 2 of the Rural Health Workshop. This session is focused on whether anything can be done to stem the tide of hospital closures in rural America. Dozens of rural hospitals have closed around the country over the past 20 years, and many more are teetering. Leaders have blamed several factors, including low payments from public and private insurers, difficulty in recruiting staff, and declining utilization of some services. Many rural hospitals have joined larger health systems to help stay afloat. Telemedicine also has helped some provide specialty services. The federal government has long propped up such facilities with its Critical Access Hospital program, which uses Medicare money to fill in some funding gaps. The government recently added a new option called the Rural Emergency Hospital Program, which pays extra to hospitals that drop their inpatient units but continue to offer other vital services. Will such efforts work? That's what we'll talk about today. We're joined by George Pink, a research professor at the University of North Carolina, Chapel Hill, who studies rural healthcare issues and is great at helping reporters explain them in everyday language. He'll sum up the problems and talk about the potential solutions. Also joining us is Jared Chaffin, CEO and Chief Financial Officer of Friend Community Healthcare in Friend, Nebraska, which is one of the first in the country to convert its facility to a rural emergency hospital. Also helping out will be someone familiar to those of you who watched our first panel, Sarah Jane Tribble. Sarah is a fellow member of the Rural Affairs coverage team at KFF Health News. She's a veteran reporter who grew up in rural Kansas and has covered rural hospitals for years. George is going to start us off with a few slides summarizing the trends, and then we'll move into an informal discussion. You can ask questions at any time by typing them into the Q&A space on your screen. I will direct questions to our guest. Please do not put questions in the chat. We'll use that space to interact with you and for you to interact with each other. Thanks. George, why don't you get us started with an overview?
Great, thank you, Tony. I'm going to start off by uttering two phrases one never hears in the same sentence. I'm a professor, and I'll be brief. So over the next 5-6 minutes, I intend to give you a broad overview of rural hospital closures, where they're happening and why, and other issues. I'm going to refer to a lot of the data that I'm going to show you is on our website at the North Carolina Rural Health Research Program, including the maps that I'm about to show you. So if you want, the URL is at the bottom of the slide, or just go to North Carolina Rural Health Research Program and you can see it there. But generally speaking, rural hospital closures have been a problem in our country for a long time. In fact, going on 30 years after prospective payment systems were first introduced. There was a large number of rural hospital closures in the 1990s. Then the Critical Access Hospital Program evolved, and there was an abeyance of them for a while. And then in the early 2000s, they started to close again. So you can see at the bottom of this page, of this map, and I'll show you some more data in a second, that the numbers of rural hospital closures have gone up and increased quite dramatically during the teens, the 2000 teens. This is a summary of the number since 2014. You could see that the big drop, there was an increase from 2017 to 2020. Then there was a big drop in 2021, 2022. Many reporters usually ask me, what happened there? And the simple answer is that COVID happened. And in response to COVID, the federal government passed the CARES Act, or Congress passed the CARES Act. And part of the CARES Act was the Provider Relief Fund. The Provider Relief Fund gave billions and billions of dollars to both urban and rural hospitals. And for many rural hospitals, that was a financial lifeline. Many of those hospitals, well, some of those hospitals would have closed if that money had not been forthcoming. So we saw a huge drop in the number of rural hospital closures in 2021. But now we can see in 2022, 2023, they're starting to edge up again. So far in 2024, there's been 3 more. Why I'm putting this up is that many people in the rural health community are now concerned that because the provider relief funds are fully distributed, they're all gone, there's no more left, that we are returning to pre-COVID financial challenges and stresses facing the rural hospital community. And many people are worried that rural hospital closures are going to reemerge as another dramatic issue in the later part of this decade. Why do rural hospitals close? Well, we do academic research on the reasons why. This is a study that's going to be coming out soon on what the news media reported as the reasons for closure, rural hospital closures and their causes. And we went back, we analyzed 140 hospital closures, and what the local news media reported were the reasons for those closures. And it was really quite gratifying because most of what we read in the news media also agreed with what we had found in our academic research. But generally speaking, there's sort of two large buckets of reasons why these closures are happening. The first and probably the most important bucket is the financial bucket. Typically, rural hospitals that closed have been losing money for many years. This is not an overnight phenomenon. A hospital does not lose money one year and say, okay, we'll close. Typically, they've been losing money for 3, 4, 5, 10 years even. But they draw down their reserves, they sell off their assets, they max out their credit, and they just lose, and they just have nowhere else to turn other than acquisition by a system sometimes. But if they can't find a system partner, then they might declare bankruptcy and close. They often operate in markets where the financial resources are poor. Patients are a lot of high rates of uninsurance, underinsurance, Medicare, Medicaid are high proportions of their payers, lots of uncompensated care, shrinking markets, and so on. There's just a whole slew of different financial reasons that might be at play here. And then the second factor is sort of the patient bucket. Small markets, declining populations, perhaps patients aren't going to the local hospital, they're driving further to go to the larger city hospital, for example. Sometimes there is uninsurance and so on as well. So the demographics, the low patient volume is another significant factor. What struck us most from reviewing the news media articles is the diversity of the reasons for closure. There's not a most common factor. Every town had a different set of circumstances that came together that resulted in the closure of the hospital. And many of these reasons are not in our secondary databases. The CEO left. Some physicians in the community retired. There were some fraud or safety concerns. Those kinds of things don't appear in secondary databases. So the only message I really want to leave you with is that closures are a very complicated phenomenon. No two towns are the same. As a result, we've had for discussion for about 10 years now. I think Senator Grassley was actually the first one among the first politicians to float legislation to create a new beast in response to this closure phenomenon. And because the closures have dramatic effects on the communities that they serve, Senator Grassley and others since then thought, well, we need a new model where the hospital can survive on a long-term basis. And that led to the creation of the rural emergency hospitals. Jared's going to tell you much more about that model. I will just tell you that right now we are tracking them at the North Carolina Health Research Program. There are 30 hospitals to date have converted. So they used to be inpatient hospitals. Now they're called rural emergency hospitals. You can see most of them are in the South. Some are in the Midwest, and very few in the West or the Pacific Northwest yet as well. So with that, I'm going to stop talking, and I'm going to turn it over to Tony again.
Thank you so much, George. That was very helpful, and I'm glad you're liking, in general, what you're seeing in the media report, that we're getting it most of the way right. Jared, talk to us about, describe your hospital and talk to us about how you came to decide to join the Rural Emergency Hospital Program and how's it going?
Yeah, so my hospital is in a community of 900. We are the last city-owned hospital in the state of Nebraska. Um, so being city-owned, we don't have millions sitting in an endowment. We don't have any private uh, investors, or we don't have a mothership. You know, a lot of rural hospitals are a part of uh, hospital systems. We are not. It's just us. So uh, we were a 15, used to be a 15 bed critical care or critical access hospital, and went to REH in January of this year. Uh, Last summer is when we started looking really heavy into REH. We were literally hours, probably 1 to 2 hours from closing our doors permanently last June, um, mainly because we just could not make payroll. And we, one of our board members had approached everyone about REH earlier in the year because he had saw it in an article, and me and some of the other admin staff had not seen it. I'd never heard of it before he brought it to us, and we've been talking on it. And then, you know, when we were in June and not being able to make payroll, and we had to get $250,000 from the city because, again, we're city owned. That's the only place we can go to get funding if we need it. Um, we made a decision at that time. We thought REH was the path we had to go. We're our uh, George. The two things you showed, financial, and then other things like geographical and whatnot. That's us in a nutshell. We've been having losses. So I've been here for a year and a half. I can see records back to 2016. We've been losing money ever since then. Um, we may have had net income, but if you look at income from operations, it's always been negative. Um, you
What was the reaction in the community when you first broached it? Was it hard for people to accept that you'd still be a hospital if you didn't have an inpatient unit?
it was. We did have a handful of folks in town who were frustrated, who were not happy that we would be losing inpatient or swing bed, but most of the town understood we had to, make a business decision. We are a hospital, and our customers are patients, and we're there to take care of human life, but we are also a business. And businesses either, make enough money to stay open or they don't. And we held a town hall meeting in June, July of last year, and invited the entire community. Um, we had folks from our surrounding communities show up to that town hall, which was pretty cool. But we basically explained, here's what a CAH is, here's what an REH is, here are the things that are going to be different. But then I had also put together analysis of uh, what the finances could potentially look like if we went REH. And once we got through the presentation, we literally asked the community for a raise of hands. Who wants REH? Who wants CAH? And it was easily 90 to 10, 80 to 20 REH. And that's when we decided, okay, that's the direction we're going. We are still, and we officially transitioned on January 11th of this year, so it's been 8 months, but we still have some struggles in the community of folks who are still upset that we don't do inpatient or swing beds. So that's one thing with small communities. When feathers get ruffled, it can take time to
Sure.
get them smoothed out. So
How has it gone compared to your expectations? Is it going pretty well, or
yeah,
anything surprise you about the change?
um, I mean, we thought our staffing was going to be drastically different, but it's not. We still kind of have the same staffing, and when I say staffing, I'm talking mainly clinical. So your nurses, your uh, radiology, lab departments. Because as an REH, you have an ED 24/7, so you still have to have lab and radiology, um, an RN, and a provider there on site. So none of that's changed from being a critical access hospital. Um, I will say this time last year, we were around a $1.7 million loss through the first 8 months. Or our fiscal year is September to uh, August. So through the first 10 months of last year, we had a $1.7 million loss. This year, we're at break even. So we have been able to drastically turn around the hospital. Um, and it's been amazing to be able to uh, pay bills, and we've paid off $1 million of debts within the last 6 months since January or February, and yeah, it's still a struggle. Um, we still don't have hundreds of thousands of dollars in savings. I still, from a CFO seat, I still live every 2 weeks to 2 weeks to 2 weeks because that's when payroll is, and I just make sure I have enough for payroll. And in between payrolls, I'm trying to get as much vendors paid as I can. Um, but I still can't make all of our current payments because I still have a lot of old stuff that I have to take care of. And until all the old stuff goes away, I can't focus 100% on the current stuff. But, you know, I mean, it's, I think everyone can see the hamster wheel. As you don't pay this month and you pay last month, well, the next month comes and this month is now the last month. So you're never going to get caught up.
Yeah.
And one of the main reasons of that is the REH money that you receive. It's not there to make your hospital rich. It's not there to, um, allow the hospital to do all these crazy outpatient procedures and, throw in a $500,000 X-ray machine or things like that. It's there to help you, um, stabilize and just keep your hospital moving. Keep that ED open. It's really for the ED.
What, why do you think more hospitals haven't jumped at it? When I first heard about this a few years ago, because I'm in Senator Grassley's state of Iowa, I started hearing about it early. It sounded like something a lot of hospitals would jump at, but so far it hasn't been. Do you expect more, and why do you think people are hesitating?
I do expect more. I mean, we were number 21. Now there's 30. I think change is scary. When the critical access hospital designation came out, it was a slow start. It took um, a couple to a few years to really take off. And now there's lots of critical access hospitals. So I think it's just going to take time and understanding. I think people are scared to death of losing inpatient and swing bed. But I'll tell you the number one thing from a finance perspective is people are scared of losing cost reimbursement. So as a critical access hospital, you are cost reimbursed.
Help explain briefly what that means.
Yeah, so let's say someone comes into the ED and the cost of that visit is, let's say, $10,000. That $10,000 covers, your nurse and provider who saw them in the ED. It covers any cost of lab and radiology, if there was an X-ray, if there was, blood drawn, tested. It covers utilities. It covers everything that you just incurred during that visit. You get reimbursed for that. 100% cost reimbursed. So you would get the $10,000 in theory. A lot of that is handled through the cost report that we have to file at the end of the year.
Mhm.
So as a critical access hospital, there's things like for your swing bed, you get what's called per diems. You get X amount of dollars per day for a patient on your floor. That per diem amount is different based on your cost to charge ratio as a hospital. And since our volume was really low, um, our per diem was pretty large each day for each of our patients because our cost per patient was staggeringly high. Um, so you go throughout the year, you get reimbursed based on, cost to charge ratio, if you want to call it that. And then end of the year, you file a cost report, and then Medicare says, "Yep, we either underpaid you, overpaid you, or paid you just enough."
But in the end, the extra bump you get in other ways is better than that. You decided under REH.
For us, yeah.
Okay. George, I'm sorry, Jared. George, what are your thoughts on why more hospitals aren't jumping at this, and do you expect to see more?
Yeah, I think I totally agree with Jared. I think the CAH analogy is a very good one. The Critical Access Hospitals legislation was passed in 1996. There were few uptakes in the year or two following, and in fact, it required congressional fixes before it really started to take off as a hospital program. And I predict that's what's going to happen here. And NRHA, National Rural Health Association, recently published a letter that has a laundry list of technical fixes to the legislation that are inhibiting a lot of hospitals from converting to REH. Jared mentioned a couple of them, but another big one is the loss of 340B revenue. That alone is keeping a lot of hospitals from jumping into the REH model because many hospitals, many critical access hospitals in particular, need that money to break even. They're not making, like Jared says, no one's making a lot of money here. We're talking about break even or having losses as small as possible.
And
So I expect if Congress addresses some of these technical issues and makes it more appealing for our hospitals to convert to this model, I wouldn't be surprised to see an uptick. If they do nothing, it may be a much slower uptake.
it's interesting because here in Iowa, when they first came out with the critical access hospital program, not a single hospital qualified under the rules originally, not one. And that got changed. It helped that our senator was chair of the finance committee. But now 2/3 of the state's hospitals are critical access, even though none originally qualified. So yeah, do you think that there's appetite in Congress to change it? And you know what? I'm going to throw that to Sarah Jane. Sarah Jane, from what you understand, are people expecting there will be some changes, or is it too soon to know?
I think it's too soon to know. I mean, I think that right now Congress is sort of a mess, I think, to use a technical term. They're hoping to put it on as a rider at some of the appropriation bills at the end of the year, but I say that with the caveat, I have not interviewed anybody on this in the last month or two. I do want, if I may, Tony, I've written a lot about this. I wrote a recent story on 340B being the hindrance to hospitals signing on for the REH. And
Please.
what Jared just talked about was super interesting to me because what he is describing is being able to pay his bills, which is really interesting because I actually haven't had a chance to ask a hospital operator, when you are an REH, you have to get rid of your inpatient beds, but you get a bump in funding, a lump sum in funding, right? And you can correct me. I think it's 1.3 million about, is that correct?
3.2.
3.2?
Mhm.
Okay, so thank you. See, that's how long it's been since I've written about this. And that 3.2, do you get it paid? Like, how is it helping you right now? Do you get it paid at the end of the year, in quarters? How are you getting it?
It's monthly, so it's about $277,000 a month, and it's on Either the first, second, or third of the month, so very beginning, and then I'm able to take that 277. You can kind of sort of do what you want with it. You just have to keep record of what you use it for. But I take that 277. I know I have two payrolls a month, so I immediately take that out of the 277, and that leaves me with what I'm left to pay vendors, bills, loans. Obviously, we have more money coming in from the outpatient services we do, and um, ED
Did you get a bump in funding on your outpatient when you switched to the REH?
Yeah, you get 5%.
That's what I thought.
Yeah, so you get put on the OPPS schedule, but then you get like a 5% bump, which I mean it's something, but it's not crazy. That's one of the things I've noticed is the drastic distance or difference between our reimbursements as a critical access hospital and now as an REH.
And
We get so little reimbursement now, even with the 5%.
you get so little reimbursement on your per patient
Yes.
now. And so when you were critical access, you had 25 beds, but how many, because that's sort of the definition of a critical access hospital. I mean, part of the definition is you can't have more than 25 beds, right? And you get paid a different way. How many beds did you fill on an average night before the REH?
So I mean, if you were to look at the last 3-4 years, our census was probably at 1.2.
Wow.
Now there were times in there where we had 6 on the floor, but that would last a month or two, and then it would go back to 1. In fact, in COVID, I wasn't at the hospital during COVID. I was in Tennessee. I'm from Tennessee. So I got here in December of 22, but in sometime in 21, we had 0 patients on the floor for about 7 months. The only reason our facility stayed open through COVID was all of the federal funding. Or else we would have completely closed our doors. And last summer, now that all the federal funding's gone, time caught up to us. Yeah, another thing to think about for us, and I think this is one thing that a lot of facilities may come across, is our geographical location in Nebraska brings so much competition to us. It's just crazy. We've got 7 hospitals all within 30 minutes to an hour of where we are. So,
and you're near Lincoln, right? You're close to Lincoln.
Yeah, so we're an hour west of Lincoln. But you've got to the right of us Crete, which is 20 minutes. You've got Geneva, which is 30 minutes to the west. Seward, which is 30 minutes north. You've got York, which is 30 minutes north this way. You've got Beatrice, Fairbury. You've got Hebron and Hastings. Oh, and in Lincoln, you've got 3 of the largest hospitals in the entire state. So when it comes to our volumes, our community, with a community of 900, not everyone's going to be sick all the time. So you have to pull from the surrounding areas of your community. Well, when you have that much choice for your healthcare, it's really hard to acquire patients.
Is it hard? Do they have bigger marketing, but like the bigger hospitals have marketing budgets? Is it hard for a small hospital to compete for patients when you don't have that kind of marketing budget, or is that not something you're seeing?
It's very difficult, but I wouldn't say it's based on marketing. It's based on what you can provide. A lot of patients do not want to go to this hospital to see a doctor. So you got to go see a specialist. Now they got to go to this facility to see the specialist. Then they have to go to this facility to get x-rays, labs. They want to do everything all at one place. So when they can go to these bigger facilities, see the doctor, see the specialist, get labs, radiology, do physical therapy, have surgery there if they need surgery, do rehab, that's where they're going to go. And it's hard to compete with that when we don't have a lot of those specialties.
Right.
Or the other thing is everyone can think of their own personal health care. When you find a doctor you like, you don't really leave that doctor. So
Right.
it's hard to um, acquire other people's patients. So yeah.
Sarah Jane, I'm going to ask you to do some heavy lifting here and briefly and clearly explain the 340B program and why it's important, because it's weedy but really important here, right?
Yeah, the 340B program is named after the statute it's written off of, and it basically provides discounted drugs. Let me see if I can say this right. Hospitals make money off the difference that they buy the drugs for and how much they get paid for the drugs, right? So if I am getting paid from Medicare $3,000 for a drug, but because I qualify for the 340B program, I only have to pay $3 for that drug, then I make thousands of dollars off that drug. There are no stipulations in the statute on how you use the money. As long as you're a qualified 340B provider, you can take that money and provide discounts to your patients, or you can take that money and build a new wing of beds if you want. Like whatever it is, it's supposed to go back in to supporting the operation. And so, in the last story I wrote, I found that a lot of rural hospitals were not switching to the REH because that 340B statute wasn't written into the REH statute. So if I become a rural emergency hospital, it doesn't guarantee, I can't use 340B. I can't be a 340B entity. The ones that I talked to in my reporting, and you can see the story on the KFF Health News website, that were most adamant about not switching to an REH, even though they had low patient volumes, were usually part of larger regional or bigger health systems, because to manage the 340B program, it takes a lot of oversight. I'm curious if Jared's hospital actually was using 340B, because what I've found in my reporting is a lot of the small independent hospitals didn't have the staff to monitor their 340, monitor and file for 340B, to buy the drugs and then also file with CMS for the permissions and all. I'm not saying that quite right, but I'm curious, Jared, were you guys using 340B?
Yeah, we were. So we had a 24 hour pharmacist. She'd be on site, 8-10 hours a day and then on call the rest. But she ran our 340B. We have a local pharmacy here in town. And you're correct. Like you get through 340B, you get a discount on what you pay for it, but you also get a part of the revenue that the pharmacy makes down the street when they sell a drug to your patient. So whenever we would write scripts for our patients and they would go down to the pharmacy down the street and get whatever script they need, we would get a piece of that revenue as well. So there was a potential to make quite a bit of money. Our hospital didn't. We may have made 30 grand the last couple of years on 340B. And when I say make, that's through the pharmacy. That's not the cost savings. I don't know the exact number of the cost savings because our system is pretty antiquated and doesn't keep track of that. But I am seeing the cost difference now. So for example, this will be a good example to see how 340B hurts, not being in an REH. So as a critical access hospital, we could give a shot of Avinity or Prolia. Both of those are for osteoporosis. We could give a shot of those, and after paying for the shot and after reimbursement, we were making around $4,000 or $5,000 a shot.
Wow.
Okay?
In the suggested changes to the law include letting REHs back in that program, right?
Yeah, and one should note that these drugs that get the discount that are part of the program are only outpatient drugs. It's not what you would provide inpatient. So it kind of makes sense if you think about the requirement for the outpatient for REH. It really would affect their revenues.
I've got a question from there's a couple questions in the from the audience.
I was-
One is from,
Tony,
oh, go ahead,
I
I'm
was-
sorry.
I was trying to get through that. Basically, what I was trying to explain to everyone was we made $4,000 or $5,000 a shot as a critical access. Now that we're REH, it cost us $40.
Oh my gosh.
So that's the drastic difference between having 340B and not having 340B, but also losing cost reimbursement. So to your earlier question of why people haven't moved to this, it's scary because you're losing not only reduced cost through 340B, you're also getting reimbursement. So I went from making $5,000 for giving someone a shot to it costing me $40. So
Wow.
it's a drastic difference. But yeah.
So if they change that one thing, do you think, and George, maybe you can chime in here too, do you think that we'll see a lot more interest in the rural emergency hospital program?
I think it will affect the amount of interest, whether there'll be a doubling of it or whatever, I don't know, because there are other fixes with it, a lot of other proposed fixes as well. Labs, for example, lab work does not get the 5% bump that Jared's been talking about. Swing beds, obstetrics and maternity care. There's a lot of issues that have yet to be dealt with, I think. 340B in itself would be a help, but I'm not sure it would result in a windfall of new hospitals.
Gotcha. A question from the audience, from Aaron Bolton in Montana. He says, I've been wondering why we're not seeing as many rural hospital closures in the Rocky Mountain region. What makes hospitals here different than the facilities closing in the Southeast? What's going on, George? Why is it so regional?
Well, there's like every other academic response, there's a long list. It depends, and it's complicated. In the South, there are more hospitals than there are typically in the Western states. So bigger counties and so on as well. But typically, there's more poverty, there's more poor health. And there's lower rates of reimbursement in the South compared to other regions in the country. There's staffing issues, there's EMS issues. There's a lot of different reasons for it. I can't point to one. I don't know if anybody else can point to one or two major reasons, but those are the types of things. Volume, payment are always at the top of the list.
Yeah, and don't forget Medicaid expansion. Southern states are the biggest block in the US that haven't expanded Medicaid. So that goes to Georgia's reimbursement.
So is a hospital less likely to close if it's the only one around for a pretty big area? Like Jared was talking about how he's got several competitors not too far away, but if you're way out in Montana or Wyoming, maybe you're less likely to have that competition?
I'm not aware of any studies that show that, but I certainly, in the media report of closures, we certainly found competition as a factor that explained some rural hospital closures.
I'm not quite sure I understand this question, but maybe you do, George. Any data on trickle-down impacts to community anchor tenant hospital? Like, how does it affect the community?
Yeah, I mean, it's a good question. Again, and on the work we've just finished looking at the news media, we find that there are three major consequences when a rural hospital closes in a community. First is obviously the lack of access, the reduction in access to hospital care, the access to inpatient, outpatient care, and so on. There's the loss of the hospital jobs. There's a loss of sometimes the tax revenue to the county and the local town, and just the direct economic effects. The hospital is often the largest employer in the town, so the largest employer closes. That's going to have a drastic economic effect on the town. The second effect are sort of the indirect effects on the community. So I think what the questioner is asking is that not only does the community lose the hospital jobs, but often many of the professionals, healthcare professionals in the town who rely on the hospital, are not hospital employees, but they rely on the hospital for referrals and so on. They will often leave. There have been studies showing that physicians leave towns quite often when the rural hospital closes. So there's the indirect consequences to the community. And then thirdly, there's the indirect costs to the patient. You know, you're thinking when many rural areas where these hospitals have closed, they've got a large numbers of patients who are poor, who are elderly, who are disabled. And for them to travel 5, 10, 15 miles to the next town to get care, that is a huge access barrier. And even if they can manage the access, they're going to face hotel costs, transportation costs that they didn't have to incur before. Yeah. So I think if I'm reading the question from the person correctly, there are huge economic and social consequences to those communities where the rural hospital closes. Has it? Can you recommend? I'm not aware of it.
Can you recommend good sources of independent data? Has anybody quantified the effect that you know of?
No, I have not seen. Well, there's one study in health services research by one of my colleagues actually 3 years ago, looking at the community economic consequences. I can get that reference and send it to you, Tony, if you like.
Okay. I would also say, let me just add in, since I've been to a lot of these communities, ask about income levels, because the hospitals are usually some of the best payers for salaries in town. And when those jobs are lost, people stop going to the deli, they stop shopping. It really has a trickle down effect when you start thinking about, you know, the nurses and the people who worked at those hospitals losing their jobs and not having those incomes. Or they start traveling to the other communities for their jobs and start spending their monies in the other communities.
Sorry, I should also say the KFF had a great article on the communities where hospitals closed about 4 or 5 years ago. Sarah, Jane, I can't remember.
I have a great passion for covering these communities, so I write a lot about it.
But it was a really good article because it went into the communities and examined community by community what the consequences of the closures were. So I would really urge people to read that article.
Another question from the audience, how has the rise of Medicare Advantage affected these closures? And George, I think I'm going to throw that to you first. And can you briefly explain what Medicare Advantage is and then how it plays into the closures?
Yes, I'm really curious to hear what Jared has to say about this in terms of how it's affecting his REH. But Medicare Advantage has been identified by many rural advocates as a real problem, an emerging financial problem for many rural hospitals. Essentially, it's private insurance. It's Medicare. It pays a monthly amount to an insurance company, and they manage the care for the Medicare beneficiary on behalf of the Medicare program. Whereas traditional Medicare, when somebody goes to Jared's REH, we use it with traditional Medicare, there's a standard fee and Medicare pays that fee. But Medicare Advantage negotiates fees with rural hospitals, and they have a lot stricter pre-authorization. They take longer to pay. They have more higher rates of denials. So we're hearing a lot of horror stories from many rural facilities that as the percentage of their business that's Medicare Advantage, as it's growing, that is starting to impose real financial consequences to the facilities. I'll stop there because I'm dying to hear what Jared has to say.
Yeah, Jared, how's it affected your about what percentage of your patients who are in Medicare are on Medicare Advantage, and how has that affected your business?
We've got I'd say about 13% are Medicare Advantage of our patients, and it's
13% of all patients or 13% of Medicare patients?
13% of all.
Okay.
We've had a massive uptick in that arena of insurance, and it is absolutely afforded. It seems like with managed care, this is a joke, but it seems like you have to have a pre-approval to get a Tylenol. You have to have pre-approvals for everything. And if you do not get one, you do not get reimbursed 1 cent. They will not reimburse you for anything. So you've got to have good front office people knowing, okay, when they see this managed care, oh, they need pre-approval because you go to do a procedure on them or a CT scan or whatever, and you don't get pre-approval, all of that is gone. You are not seeing any reimbursement for that. So that's one reason why it's hurting rural communities is some places may not have that skilled office person that recognizes, hey, I need to get pre-approval for this patient. A lot, because I'll tell you this, 99% of the time the patients don't know they have to have pre-approval.
Right.
That's on us as a hospital to let them know, hey, we can't do this just yet. We got to get an insurance approval, then we can set this up and do it. The other piece to managed care is, yeah, they deny and deny and deny. You can have, this is not a joke because I have seen this. You could have an extra space in your facility's tax ID number, and they'll deny the claim because your tax ID number did not correlate with what it actually is because of an additional space.
Wow.
So they are doing everything they can. I like to call it a witch hunt, but they're doing everything they can to deny claims, and it is destroying hospitals like mine because healthcare is one of the only, if not the only industry to where you provide a service and can wait a year to get paid. It's we put all this money into y'all were saying earlier, payroll salaries. We are the best paying facility in our community. One, we have 50 employees. 40 of us come from other communities. I don't live in the community my hospitals. So 40 of us come in. And that's the other thing rural hospitals deal with. If you don't have the talent of folks you need in your community, you have to pull them from elsewhere. Well, I drive an hour each way. So I'm on the road. I drive 120 miles a day to go to and from the facility. You have to pay people to do that. You have to pay people well. Our nurses are very well paid, but to compensate them for coming in. But anywho, managed care has, I think, destroyed.
And it's getting more so, right? There's more and more people joining. And in my experience, some people don't even realize they're in managed care. Like they don't realize their Medicare is managed care. Jane,
they don't.
you've written.
Yeah, there's an increase in rural enrollment and an increased push for Medicare Advantage plans in rural areas. I did a story on this last year, and the data is showing that there is an increased push to get into rural areas, and there's an increase in enrollment correlated with the increased marketing. And so if you are a senior living in a rural area, you might get a few phone calls a day, something in the mail every day, asking you and telling you that this is the better Medicare to sign up for. And Congress has held hearings on Medicare Advantage. There have been recommendations about prior authorizations that are being put into place. And there's a lot of conversation at the federal level about Medicare Advantage. But for us covering rural healthcare, what we need to know is in the last year, it's really stepped up in areas. It was always pretty popular in the upper Midwest, Minnesota, and so forth. But now, I've talked to hospital CEOs in Alabama saying that it's causing them to shut down.
And they have to
there's
negotiate separate contracts with each carrier in their area, right?
Yeah.
In Medicaid has managed care in it too, and it's some of the same companies are doing.
It is some of the same companies. I haven't done any reporting on that. I would instruct anybody who really wants to read about Medicare Advantage to look at ProPublica because they've done a lot of investigative work on United Healthcare, which has prompted some of those federal questions from Congress. But
and
yeah, I haven't.
How would they bring that home for their readers? If you're a local reporter, how would you write about that in a way that's going to resonate with folks?
If I'm a local reporter and I'm talking to patients and they start talking about their insurance coverage, I definitely always want to see their card because most people don't know what insurance they have, especially if they have Medicare Advantage, they might think they have regular Medicare. And that helps then frame your questions about the kind of payments that you're having to make as a patient and what kind of payments the hospital and town are getting. And then if you're reporting about your local hospital, and it's a regional health system or a smaller community hospital, I would definitely ask about payer mix. I always do. It's one of my top 5 questions is what's your payer mix? How much Medicare do you have? How much Medicaid? How much, charity care do you have? But I would probably add in Medicare Advantage. How's that hitting your area right now? I think we're going to hear a lot more about Medicare Advantage and the impacts of it on rural hospitals in the coming couple of years.
And I think it would help the average person to see an explanation of what these plans are and how it might affect your local healthcare system. Like, I don't think people even know to think about that.
Well, I mean, if you have, sources or older folks who are, approaching Medicare age, they're likely getting the advertisements in the mail. And, I've been in rural areas and seen billboards for Medicare Advantage insurance agents, and they advertise things like food cards and, vision care and things that Medicare does not provide. And Medicare itself is a complicated alphabet soup for any enrollee that's signing up. And, it's really easy, I think, for the average person to make the mistake and sign up. I shouldn't say mistake, but not know exactly what they're signing up for when they sign up. And I mean, research has found that some people really love their Medicare Advantage plans. Some people are very loyal to their Medicare Advantage plans. Others not so happy once they have it.
I think there's good stories to be done there for reporters, including local reporters, because if you're a senior, it's unbelievable how many calls you get, how much mail you get, and it's baffling. I mean, I've been at my dad's in his 80s and lives in a small town, Wisconsin, and I've been at his house when it's re-enrollment time, and the phone just rings off the hook. And it's these Medicare Advantage plans trying to get him to switch. So I do think that there's a good story for folks to do related to that. There's a question, it's just a clarification for Jared. When you said critical access hospital payments were based on cost, is it cost plus? Do you get a little bump on top of that if you're a critical access hospital? It's like 1% or 2% more?
It's like 1%.
Okay.
We were like right at 101%. So yeah.
Okay. The rural emergency hospitals, can a community one, George, or does it have to be a conversion of a existing hospital? And is there any talk about changing that and letting people start new ones?
Yes, I'll ask Sarah Jane to confirm this, but my understanding is that under the existing legislation, you had to be open and have a license as of December something in 2020, I think was what the legislation stated.
Yeah.
The REH2, the legislation that was introduced based on a lot of what NRHA had on its laundry list, proposes to extend that backwards to allow hospitals that closed before that period to reapply as REHs as well. So that's another example of a technical fix that might be forthcoming from Congress. But right now, I think the legislation said you had to be open as a hospital on December something 2020.
Yeah, I think it's a conversion only. I was just looking at this the other day because I'm working on another story. And I think you can't just build an REH.
If they allowed that, would there be interest in it, do you think? Does anybody think? In some communities that don't have a hospital at all now?
Well, I mean, you have standalone emergency rooms in
Right.
Texas and in various states. I do think that there probably would be interest in, that, but I haven't interviewed a ton of experts on it. I just I'm working on a story where it sounds like, there would be interest.
And then, Jared, I was surprised to hear you say that you didn't have anybody in your beds during the height of COVID. I know in my area in Iowa, there were some small hospitals that had a surge during the worst of COVID because the big city hospitals were full and were begging the smaller hospitals to hang on to any inpatients they could hang on to instead of sending them into Des Moines or Iowa City. Does that give any pause to people now thinking about closing down their inpatient beds as maybe there will be a crisis when we do need them again? I guess, have you heard of that, or is that not the case at all in your area, that small hospitals got really busy in their inpatient units for a few months during the height of COVID?
I'm not sure. I wasn't. I was not in Nebraska.
Okay,
COVID. I was working for HCA and at bigger hospitals.
sure.
This is my first rural hospital to be a part of. I don't know what it was like around here, but I mean, where I was, yeah, every bed we had was full of COVID. But I would assume um, we did not have patients, mainly because all the other hospitals had them. My facility is basically the last on the list that ever gets called. Um, we just we don't have all of the things that everyone around us have for whatever reason. That is a, it's taken probably 30 years to get to where we're at, and there's things that our facility went through in the early 2000s, 2000 to 2004. I was in high school, so way before me, that we're still dealing with today. And again, that's just small town politics, small town feelings.
You're making me want to look up the court records for that hospital, Jared.
Oh, nothing like that. It's just hometown politics. There's nothing you won't find anything in the courts. There was nothing illegal or anything. It's just we opened up a clinic. There was a clinic down the street owned by one of the providers of our hospital, and it created a feud. Um, that provider did not sell that clinic to us. He sold it to Brian. Brian is a very massive, large hospital system in Nebraska, and it split our community in half, 50-50. So 50% are for the hospital, 50% are against the hospital. So we have 50% of the town who don't even come to us. Well, this was all 2000 to 2005, 2004, and we're still dealing with it today. So there's multiple reasons why rural hospitals go through what they go through. I just mentioned that because that's one of them. It's not always just Congress and healthcare and whatever else that is hurting um, hometown hospitals. It could be stupid crap
Sure.
like the politics that we're going through,
Sure.
20 years ago. So
That's probably true in every town.
absolutely. So
I wanted to ask another question from the audience. And I guess this is for George. What could you speak to the demographic characteristics of people who live in rural areas who may be affected by closures? Are there areas of the country where the populations are younger? What are patterns you've seen by race and ethnicity? And do those things play into whether a hospital does close or how the area is affected?
Yeah, that's a good question. So when we talk about rural areas, the most common phrase you hear is older, sicker, and poorer. That rural areas have got higher proportions of elderly people. They tend to be in poorer health, and there's a higher rates of disability and so on as well. So those kinds of areas that have got communities which have got extraordinarily high levels of those folks, very poor in particular, those communities are going to have a higher probability of the rural hospital closing. There have been some studies, one of them by a colleague of mine, I think about 5 years ago, that found that rural hospitals that closed were more likely to be in communities with higher rates of a higher proportion of people of color and underserved, disadvantaged communities. There's also been some studies looking at, because in our research program, we differentiate between closures and conversions. Closures are hospitals that are buildings with healthcare in them, and then they totally close. There's no healthcare services left at all. They become an apartment building or an office building, or they're blown up. Conversions are hospitals that still provide some sort of health care, but no longer provide inpatient care. So they convert, they morph into a skilled nursing facility or a clinic of some sort or whatever else. There was a study a few years ago that found that hospitals that close, communities that face closed hospitals, again, we're more likely to serve disadvantaged communities and have higher rate proportions of people who historically have been underserved. So
Was that study from your group
yeah,
at UNC?
yes,
So if folks are looking for it, they could go to
they can find it on our website. Yes,
in that's the Shep Center at
Mhm.
UNC, SHEP,
Yes.
if folks are looking for it. Well, and it's not what and the thing I'm thinking of when you say that, George, is so those are the places with more older and poorer people are more likely to have their hospital closed. Also, and those are the people who are most affected by it, right? If you don't have good transportation or you can no longer drive. So it's kind of a double whammy, right?
Well, I'm curious if Jared could shed some light on who his patient population is now. He talked a little bit about the competition from surrounding areas and how his hospital had been sort of the last one or is last on the list. You know, if I think we've all heard of the bypass effect, which is this idea that the local community drives past the local hospital because they want to go get the 3D mammogram and, you know, the bigger community that has the bigger health system, right? And so Jared, I'm curious about who your patients are. If they are in my mind, the people who can't travel, the people who can't move, and if that's really who ends up at some of these local hospitals.
Yeah. So our demographics are 99.9% white. Uh, and we are a very well-to-do community. We have very well-to-do farmers. Um, Farming in Nebraska is you can make pretty good living if you have a lot of land. We do have a population that is probably just over the poverty line. Um, I haven't seen any like straight poverty with my own eyes in our community, but there are lower income folks, and there are folks who can't travel. We have a very, very high um, elderly population when it comes to the people we serve in our clinic, and then also for outpatient procedures. Um, our EDs kind of all over the place because we get EDs from people passing through the community. We have a pretty major highway that goes through town. We even got a patient from the train. So we have trains that go all through Nebraska with
Yeah.
stuff and Union Pacific. Well, we got one of their conductors in a couple of months ago because he was having chest pain. So
Wow.
ED's kind of all over, but our day in and day out patients are elderly or young. We see a lot of kids in our clinic. We do have a school right behind us. Um, but I completely agree with George. Being from Tennessee myself, a lot of your rural uh, facilities are in your less fortunate communities. Um, but it is interesting to see a community like mine that is not less fortunate and quite fortunate. We can still have the same issue of
Sure.
closure.
Sure.
And it again, I let my community know during that town hall, use it or lose it. If you want us here, you have to use us.
Sure.
You know, if you want to go down the street or go into town, like Sarah Jane said, to go get this bougie mammogram or whatever, that's fine, but there's a risk we're not going to be here when you get back.
Interesting.
Can I just follow up? And that is your percentage of patients who are poor compared to the percentage of poor in the community, or your percentage of well-to-do patients compared to the percentage of well-to-do in the community. Is it even, or are you seeing it lopsided in some way?
We have more. Oh, percentage of patients.
Like, are you the place where people who have certain income levels are more likely to go to, and people who have other income levels are more likely to bypass you? And maybe that's a mean question to ask, but now I'm here and I'm asking it. So
Yes, yes, you are correct. I
okay.
know what you're asking. Yes.
So if you have private insurance, you might be more likely to go to the big city, or if you have a good car and a flexible job.
Yeah, but another piece to that though is a lot of our and see that's like George was we could talk hours on how this stuff works, but the more well-to-do folks, either they're farmers and farmers just don't come to the hospital. A farmer, uh, again, this could be me, but a farmer could almost slice his arm off a machine and be like, "Oh, just throw some dirt on it. I've got work to do." That's just the way farmers are. Um, they're really busy. They don't necessarily take care of their healthcare like they need to. Folks like me who are finance, engineer, this and that, those people in our community work in Lincoln or work in a bigger city because those jobs aren't in our community. Well, they're going to their healthcare in the bigger city because that's where they're at. You know, if they get out of work at 4 or 5, they're going to go to a clinic there instead of driving all the way back home and risking our clinic being closed. So there's so many reasons, demographic reasons and variables, how, what, when, where, why hospitals do or don't get patients. But yeah, I mean, a lot of our more well-to-do, it's either they just don't get their healthcare taken care of, or they're, going elsewhere for whatever reasons. So we do have a lot of more indigent crowd, I guess, but also an elderly crowd, which as a critical access hospital, Medicare was our best payer, and now it's our worst.
Interesting.
Age.
Wow. George, real quick, we're close on time. It's not just that hospitals are closing, but other hospitals that are remaining open, a lot of them are dropping some services, including, I'm thinking, obstetrics units, inpatient mental health, cancer care. Do you expect that trend to continue? Where are we at with that?
Do I expect the trend to continue? Yes, if nothing else happens. There are a couple of bills before Congress now that specifically address the closures of obstetrics and gynecology units in hospitals in rural areas. I haven't seen much on cancer, behavioral health, but certainly obstetrics has got a lot of attention. But it's a big problem because I don't know any rural hospital who's ever told me, yeah, we make a lot of money on obstetrics.
Right.
We just don't. Medicaid,
And a lot of them have a lot fewer cases than they used to.
yeah. But the primary purpose, I think, is the cost, the overhead of maintaining an OB unit is high, and Medicaid is the major payer, and in most states, Medicaid is a lousy payer and so it's just financially, it's very, very difficult for most rural hospitals to maintain a viable obstetric services, as well as shortages of OBGYN and nurses and anesthetists and so on as well.
I mean, if you
And
think about
Medicaid is a much bigger payer in rural areas, a lot of rural areas than average, right? That a higher percentage including of obstetrics patients, are on Medicaid in rural areas than in, say, suburban areas.
Yes, it's still, Medicare is a much larger percentage, but
Right.
yes, Medicaid
But if
is,
you're talking obstetrics,
yes, and over half. I don't know what it is nationally, but I know in North Carolina, more than half of all births are Medicaid births.
yeah, that's the way it is in a lot of states, actually. And if you think about obstetrics units, and I think, and correct me if I'm wrong, you guys, but you've got the anesthesiologist you have to have on staff. You have to have a general surgeon on staff. So it's more than just like an OB. And finding a specialist, period, for rural hospitals is very difficult. To find several specialists to support an OB unit and keep them there, it's extremely challenging. So it's not only the fact that these don't pay well, it's also the fact of staffing these obstetrics units is an extreme challenge for a lot of these facilities.
And if anybody's covering it, I would recommend that you ask for data on how many births they were handling and go back 10 or 20 years. Because for a lot of places, it's dropped by more than half because people just aren't having nearly as many kids. And there aren't as many young families in those towns. Well, we're a couple minutes out. I'll ask each of you real briefly if you have any last thoughts on what reporters should think about doing in covering this issue. What would you like to see more of? George, why don't you start?
I have several ideas for stories that I don't think are being told well enough. One is the effect of closures on disabled people. I think there's been some coverage of other disadvantaged communities, but being a disabled person in a rural area is an extraordinary challenge, and I think they deserve more attention. The EMS system, I'm sorry we don't have more time because I'd love to hear from Jared about how the EMS system is working in his county and whether rural emergency hospitals are having the kinds of transfer problems that I'm hearing about in other states as well, because the EMS system in some counties in our country is really in rough shape and not prepared for the kinds of business that REHs might develop. Thirdly, and this isn't just because Jared's on the call, but CEO retention and recruitment is a big problem. I don't know about you folks, but I would not want Jared's job. It's a very difficult job, and finding people who are talented like he is to run these facilities is going to be an increasing problem. And then finally, a lot of our old buildings, our hospitals are old. They're decrepit, they're falling apart. There's no new technology, the roof leaks. Where are we going to get the capital to replace those facilities in the future? That's my list.
Jared, anything you'd like to see the media do that you haven't seen covered well?
I wholeheartedly agree with George, but I would just add employee retention across the board. I know he spoke about CEO, but it's hard for me to find anyone. You know, like I'm CEO, CFO. I need an accountant. It's so hard to find an accountant that has a little bit of healthcare experience because healthcare accounting is completely different than manufacturing accounting. But the one or two that I've come across, they're wanting money I can't afford.
Sure.
Again,
So staffing
they have to drive in. So
in general.
staffing in general, and then I think George is right on the folks of the rural community, your handicapped folks or even older folks. If my facility were to close, there are a handful of folks. I don't know what they would do for care. In fact, I don't know what they would do for a mill.
Yeah.
We do mills on wheels. So
Yeah.
I would just copy George's list and
Okay.
End of day, I think people just need to be educated on what an REH is and what we can do. That's the biggest thing.
Okay. Well, we're going to leave it there. We're running out of time. Thank you guys so much. If you joined us late, you'll find the recording of the session at healthjournalism.org, which is the AHCJ site, before the end of the day tomorrow. And thanks again to George and Jared and Sarah Jane. Please join the next session in your guest pass email, or I saw they dropped it in the chat. And the next session begins at 12:30 p.m. Central, which is the best time.
Thanks so much, Tony and Sarah Jane and Jared and George for joining us. We'll see everybody else in an hour.
Thank y'all.